to a gravity environment can, be a little jarring, empathic with a vestibular system. So it's responsible for maintaining balance and motion. Of course, as you've heard us say multiple times, we are going live right now on Facebook and YouTube. Hello, YouTube. We'll go one sec here. Yeah, there we go. Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. How is that for a mouthful? We need an easy name like ICN. Oh yeah, well, we can use that too. My purpose in doing this support group meeting is to make you so strong, so knowledgeable, so incredibly informed that no one can ever mess with you again. I don't want anybody who telling you that this is all in your head. I want you to be able to have good defenses. I want you to be able to know how to respond. I want you to be able to have good conversations with your doctors. I want you to be able to have control, because ultimately in the end, it's when you don't have control that you feel the worst. And so our goal here is to try to give you control. But for that to happen, we have to understand more about your unique situation. Because not everybody's the same, my friends. Not everybody is the same. Hello, Donna. Thank you. Yes, I want to apologize for not doing my meeting last week, but I totally destroyed my back. The day before, I did this massive cleaning of my house. Ended up lifting a whole bunch of heavy stuff. And I was up most of the night with my back throbbing. Hello, Heidi. Hello, Kim. So I had to take muscle relaxants. And so, yeah, you don't want to see me try to do a support group meeting on muscle relaxants, right? No, it doesn't work. It's not a good match. It's not a good match. So anyway, I want you to feel control. I want you to be like me. IC doesn't scare me. A flare doesn't scare me. If I have a flare, I know exactly what I need to do next. And that gives me great confidence. You know, one of the things that happens when you have a flare is we call it you jump off the runaway train. And that's a runaway train of fear and emotion. It's fascinating. You know, it's completely normal to be anxious when you have pain. It's completely normal to freak out when you don't know why you have pain, right? That's normal. And yet, you know, and like for me, when my IC first started, I was convinced for a year it was cancer. I mean, even to the point that I demanded exploratory surgery, which they did. I said, I don't believe you. I don't believe this is coming from my bladder. I think you've missed something with the pain that I have. I must be dying. Open me up. And they did. My gynecologist did. I was like, okay, woke up in the recovery room. Guess what? Didn't have IC. I mean, didn't have cancer, didn't have fibroids, didn't have anything like that. It was just an injured, irritated bladder. And it is absolutely stunning how painful an irritated bladder can be. You know, the pain of IC is rated equivalent to cancer pain using the McGill pain scale. It's characterized being relentless, difficult to ignore. It is agony at times. You know, it's the pain where you can't lay down, you can't sit, you can't stand, all you can do is pace. But to give you the control you need, you have to understand your unique anatomy. Now listen, if you're one of those people where you have been taking bladder medicine for years and you're not getting better, that's a sign that maybe it's not your bladder. Maybe it's not your bladder. Maybe there's something else going on. Could you have a fibroid tumor pushing on your bladder? Could you have a Tarlov cyst? Could you have tight, dysfunctional muscles? And that's where you get the confidence. Because if you keep throwing bladder therapies and nothing's working, then you know what? Maybe it's not your bladder. Maybe it's something outside of your bladder. You are an anatomical mystery to be solved. And my goal here is to teach you about that anatomy, teach you about some of the other conditions that we know can cause this, because we got to rule everything out. Hello, David. It's nice to see you. Hi, Diana. Nice to see you. Hello, Nancy. Hello, Holly. Diana says, is it common to get a nodule on your kidney with IC? Absolutely not. No, that is not common. So something else is going on there, hun. I see. So what does IC mean? What does interstitial cystitis mean? Well, that was a term created, 100 years ago, really, or even longer than that. The was that the interstitial layer of the bladder, the layer kind of underneath the bladder lining, was dysfunctional. Of course, we now know that that's not true, but the name has stuck. If you were in Europe, the only people diagnosed with interstitial cystitis in Europe are patients with Hunner's lesions or Hunner's ulcers. The rest of us would be diagnosed with either bladder pain syndrome or urologic chronic pelvic pain syndrome or pelvic pain syndrome. But getting back to your question, Diana, about kidney, there's really no connection between pelvic pain and, I mean, the kidneys are higher up, right? The kidneys are really come almost in your lower back. They have very sharp, shrill pain. I mean, it's stabbing pain when you have. The only time that I have seen a correlation between quote unquote cystitis and the kidneys is in the context of ketamine cystitis. So ketamine is a harsh chemical that is FDA approved for the treatment of depression, but it also has been a street drug for years. It has replaced heroin in around the world, and ketamine acts as basically an industrial solvent. So for people who take a lot of ketamine, what we do see is kidney damage, ureter damage, bladder damage. But other than that, I don't know. And if you see me looking over here, guys, hey, man, seriously, today's a very, very exciting day. If you have not been watching the TV, the SpaceX spacecraft has landed, and they are now in the process. The nose cone has now landed in the ocean, and they've already lifted it out of the water. They put it on the boat, and the astronauts are still in the nose cone. I'll show it to you. Right? So that's SpaceX returning to Earth. And my dream job, I actually interviewed at NASA a couple of times. From the time I was in high school, I wanted to work in NASA. And finally, the job that they offered me, because I was a presidential fellow, I earned a presidential fellowship back years ago. The job that NASA offered me 25 years ago was hatchet woman. I was to go down to Huntsville and interview the scientists involved in the Challenger accident and make recommendations as to who to fire. And I turned that offer down. I didn't want to be the hatchet woman of NASA. And I really kind of regret that. That would have been, I don't know, I was young. I was only 28 at the time. And that was a serious, serious job. Anyway, so I have to watch whatever's going on with NASA. So when the astronauts come out, I'm going to show it to you because it's really exciting. Okay, let's go back to your question. So I'm simulcasting live on Facebook and YouTube. For those of you who don't know me, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am the longest serving IC support group leader at 27 years. I bring to you 3 college degrees. I have a degree in chemistry, a degree in drug development, pharmacology, master's degree in psychology, presidential fellowship, and this IC network, our website, was my doctoral dissertation proposal in how to bring support to patients who are homebound. And ironically, I couldn't finish it because I was homebound and couldn't drive to school because sitting in a car for about 5 years hurt. Why did sitting in a car hurt so badly for me? Because it turned out I was IC subtype 4, Pudendal Neuralgia, and I couldn't sit in a car comfortably. But it is very comforting to know that 27 years later, the IC network is still rated number one in the world and in 2 peer-reviewed studies by Harvard Medical School, University of London, as the most accurate, reliable website on IC. I'm very, very, very proud of that. And look, now listen, you know it's not a support group if something doesn't fall. Okay? My prediction is my little display is going to fall at some point in time. Either that or we're going to have an earthquake, because we did have a little earthquake like an hour ago. All right. So anyway, okay, I don't even want to touch it. Hold on. Look at what we have. Finally, it's here. I got it yesterday. We have Allopath, the new aloe supplement that I'm so excited about. Because here's the reality. This is painful. Having pain and having bladder pain in particular is agony. It can be agony for many of you. And I know that because you watching it right now know you're hurting like hell. I also know that you're not able to get the traditional pain medicine that we used to be able to get 20, 25 years ago. And that many of you are suffering with absolutely nothing. And so last year, the first research study was released with a compound called palmitoethanolamide, PEA. PEA has been used for chronic pain for years in Europe. And guess what? Did their first IC research study or pelvic pain research study last year. It was presented at the American Urology Association. And PEA was stunningly successful at reducing pain in IC patients. That the combination used in the research study reduced 87% of patients had a significant reduction of the pain at month 3, and by month 6, 25% were pain-free, and the rest were significantly reduced. And these were patients who did not respond to other therapies, who were really struggling with pain. So last year, we introduced Bladder Builder, which has a bladder wall components to it, like chondroitin and quercetin and collagen with PEA. And we just did our first major research study with that, or first one-year follow-up study with that. And exactly what we expect to happen, that the great majority of patients taking Bladder Builder reported a significant reduction in their pain. 60% showed that their pain had dramatically improved. And so Allopath is the first aloe supplement that also contains PEA. Now, on my birthday, when we did my birthday broadcast, about 20, 25 of you, I'm giving away 20 to 25 bottles of this. And so I have it on my birthday. I have it right here. I already have it here in a case. I'm going to be sending those out this week. This is going to be our giveaway today also for anybody who wants to try aloe. So imagine the soothing effect of aloe combined with the pain fighting effect of PEA. And that's what we wanted to do. I wanted to, aloe has its place. It doesn't necessarily coat the bladder significantly like chondroitin does. We know chondroitin in research studies helps to restore the superficial integrity of the bladder wall, the tight junctions of the bladder wall, stuff like that. But aloe's place is that it can be quite soothing. And so we wanted to take the soothing to the nth degree. And so that's what Allopath is. And the ingredients, of course, all made in the United States. This is organic, anthracnone-free aloe. This is the best aloe you can buy. You're solid with that. It's got a little bit of calcium in it, calcium carbonate, that helps reduce acid, a little bit of magnesium in it. It's got a little bit of L-arginine and, of course, PEA. So stick around, and you might get one of these free bottles of aloe. All righty. Oh, wait, are they getting ready? They're almost getting ready to pull the astronauts out. It's on C-SPAN right now for anybody who's in front of a TV. All right, let's go back to your questions. Hold on, let me check. Now, we will be doing our Zoom meeting in about an hour. Barbara, happy birthday. Barbara says that her birthday is in 5 days. Well, happy birthday to you. It's very weird with birthdays right now, but you are loved and you are careful. I mean, you are a little careful. Where did that come from? You are loved. Absolutely. All right, let's go back to Facebook here. Hello, Mary. Hello, Stephanie. Hi, Ruth. Hi, Carol. Hi, Lorraine. Hello, Jill. Diana says, it keeps me giving me a UTI and it won't go away. Diana, what is it common to get a nodule in your kidney from IC? It keeps giving you a UTI. So you've got an infectious nodule on your kidney. That's odd. I mean, what do the doctors say about that? I mean, are the doctors just saying that it's basically a stagnant infection that, or, you know, a happy infection that simply will not resolve? Like a giant biofilm? Is that what they're saying? Like a pimple? Is it like a pimple that keeps releasing? You know, in your urethra for women, you actually do have two glands called periurethral glands that actually can become extremely chronically infected. And they are like deep pimples right next to your urethra. But I don't know about that on your kidney. Lydia says, I was wondering, does my back pain come from my IC or my pelvic floor dysfunction? It could, absolutely, because remember, the pelvis is the core, the structural core of the human body, right? Carries the weight of your torso. It also deflects the stresses when you walk. And so you've got giant muscles, your psoas muscles, that go down both sides of your spinal cord and then connect into your pelvis. And so, yes, absolutely. If your pelvic floor muscles are tight, then there's a very good chance that your psoas muscles are tight, which is a very good chance that means then, too, that you would also have back pain. When I have my worst muscle spasms, they go up the left side of my back. They go up absolutely the left side of my back. Ashley says, just getting ready to start pelvic floor physical therapy, and my therapist recommends a TENS unit. Idea on the placement of electrode pads and which TENS unit is a favorite. You know, Ashley, hold on a sec. Let me get a resource for you. There it is. All righty, here. Hold on a sec. Oh, they're getting ready to take the astronauts out. I have to see it. We have to celebrate this moment. This is a big moment. All right. So this book, Ending Female Pelvic Pain, A Woman's Manual, Ashley, is the book that really talks about where to put your TENS unit pads, et cetera. TENS units work basically by exhausting a muscle to force it to relax. So with a TENS unit, basically what they do is they have electrical pads. You put them on, you turn the TENS unit on, and it causes the muscles to twitch like that. So the muscles start twitching. TENS units should never hurt. If it's on so high that it's hurt, that is a problem, and you could damage nerves. So it should never be on to the point that it's hurting you. And so let's just see in page 224. Let's see here. Here we go. Oh, the doors are open. All right, so here we're talking location of TENS units pads. So this is one example, and so it can be along your spine or to the side of the pain, which helps reduce low back pain, hip pain, and general pelvic pain. Or this is what I've done. So you can have 4 arranged here, or 2 here, and then 2 down more over your butt cheek, which makes total sense, because especially if you have piriformis syndrome like I do, you're going to have a lot of tension in your butt cheek down here. You can have it, I apologize for the picture. I don't want to be, okay, but you can see on this picture that the pad is actually right at the base underneath the butt cheek. And then this is how they say to do it over the bladder, right? So these would be the positions that we would expect to see with a TENS unit. All right. So again, you think about how a TENS unit works. A TENS unit works by relaxing muscle. And so it just exhausts a muscle to the point that it has no choice. It has to relax. Tracy says she would love to try Allopath. Awesome. Hello, Fawad. Nice to see you. Hi, Carla. Hi, Stephanie. Hi, Carol. Hi, Christy. Annie, look at all you guys saying you want to try Allopath. Yeah, definitely. We see all these bottles here, as well as another half case that I have over here, are going to go out probably tomorrow. Cheryl says, was on a 3-day retreat with Dr. Peters. After three doctors diagnosed me with IC, he said, no IC, that you have a pudendal nerve and hypertonic pelvic floor problem. Girl, this is fantastic news. Now we know not to waste too much time doing bladder stuff. Again, if bladder therapies are not helping you, if you've taken bladder therapies for years and you're no better than you were before, or you're just maybe slightly better, but you're nowhere close to being cured or healed, listen, that's when you look beyond the bladder. We have to look beyond the bladder and see if anything else is going on. And as Cheryl said, here Cheryl goes and sees, in my opinion, the best diagnostician in the United States for IC, and that is Dr. Ken Peters at Beaumont Health in Royal Oak, Michigan. And he's where anybody in the Midwest, if you're in the Midwest area and you're struggling with a really complex case, that's where I normally refer patients who are looking for a really good diagnostic workup. And ultimately, remember my rule here. My rule is you never walk into a new doctor's office and say you have IC. That is a terrible mistake, because you will fall down the IC rabbit hole. You're going to walk into that doctor's office and your goal is to get them to study your body. We need to study your pelvis. What is happening here? Doctor, I have this pain in my lower back that refers to the front. I've got a vibration in my left butt cheek. I feel pins and needles in my vulva. I have pain as my bladder fills up. My urethra hurts, whatever. Your ability to describe your symptoms, to get them to study your body, is essential. It's essential. And that's why I don't want you to say, hey, doc, I'm here because I've been diagnosed with IC. Don't do that. Don't do that. It doesn't work. Your goal instead is to say, hey, doc, this is my situation. I've had this pain for years. It's in this location. It's always at this spot. Can you help me understand my anatomy at this location? What the hell is this? Help me. And, one of the things that I say is, listen, if you can point to a spot, like, doc, it's always here. It's always here on my left side. When I push in, it's always here. You have to get them to study that spot. You have to get them to study that spot. I was working with a wonderful gentleman who years ago, and it's like, it's always in this location every single time. And it turned out he had an infection in one of his ducts down there. It wasn't the ejaculatory duct, but it was a duct near that actually, when they actually went in and did surgery, it was black. It was fully gangrenous. And he had been diagnosed with IC for a couple of years. They completely missed it. Hello, Marisol. Lorraine says, how can I get a free gift? I would love to try it. You're going to have to stick around. Look at all you guys. Does the aloe contain gluten or lactose? I heard that drinking aloe juice can give you diarrhea. There are certain parts of the aloe plant that are well known for causing bowel issues, and that is removed in this aloe, just like it is removed in Desert Harvest aloe. Some people that, however, are just more sensitive to aloe, and it might give you gut distress. And if you're in that group, then you're not going to be able to take an aloe product. Kathy says, hello, I'm new. I would love to try it. Awesome. Where do you can order bottles right now over on the IC Network website, icnetwork.org. Just click on shop. Diana says, they thought it was cancer. Wait, hold on, Diana, I got to scroll up and see. Where? Oh, so they thought the node on your kidney was cancer, but it isn't, huh? Are they just going to cut it off? What are they going to do? Oh, we have legs. We have legs. An astronaut is being born. Oh, they just turned it away. Oh, come on. Oh, they're putting him on a gurney. Uh-oh. What does that mean? Oh, come on, guys, show us a picture. They turned it to a different camera. Oh, come on. Oh, here you go. Look. Oh, wait. See him right there? That's the astronaut. I'm such a geek. Okay. Woohoo! Okay, now I'm just going to turn this off. It's too distracting. So exciting. So exciting. Okay. Susan says, how effective is desert harvest aloe to allopath? You know, hon, you can't really compare it because allopath is not meant to do the same thing that desert harvest aloe does. Allopath is really meant to control pain. It's like desert harvest aloe with a bunch more ingredients in it, including a proven pain fighting ingredient. So I don't think that you can really make a comparison, a head-to-head comparison on them. They use the same aloe, the same organic aloe. It's just allopath is meant to do something different. Okay, so Diana had a PET scan, which found the node. Interesting. Lydia says, me too, the worst spasms are on my left side. Yeah, my worst spasms are definitely on my left side. And because I have left SI dysfunction, and of course, my left piriformis muscles are always really, really tight. Mary says, I'm getting ready to have another cystoscopy with hydrodistension, and I always have trouble words, so please say a small prayer for me. So Mary, you know why you probably have a challenge peeing is because of the type of anesthesia they're using. There are different types of anesthetics that are possibly used. The one that, and I remember, actually, it was when I had my exploratory back in September of 1993. In the recovery room, they want you to pee before you go home. I couldn't pee. Like I literally couldn't pee for 10 hours. And that's because the anesthetic they used at that time just numbed the nerves that controlled my ability to pee. And almost inexcusably, they sent me home when they should not have. They thought I had peed when I hadn't. And I finally peed like at 11 o'clock that night. It was brutal. So when I went through my hysterectomy and all that horrible stuff 3 years ago, I had 3 procedures under anesthesia before they removed my uterus and the early uterine cancer. The one thing I said to the anesthesiologist every single time is, please, I need to pee. I need to pee. Please, please. And the anesthesiologist was great. He goes, I know exactly what to do. I'm going to use Propofol. Now, Propofol's claim to fame, unfortunately, is that is what Michael Jackson died from, an overdose of Propofol. But he was using a massive amount completely inappropriately. Propofol used in surgery as an anesthetic, they use a very, very small amount. You go to sleep very quickly and you wake up very quickly. And so you really wake up. And so within 15 minutes of being in the recovery room, I could pee. It was very, very exciting. It was hey, you know what? That's exciting for me. Please let me pee, please. So ask Mary about using Propofol. They're probably already doing it anyway. All right. Also, Mary, listen, just remember that come on over to our website and make sure you read our section on hydrodistensions. We no longer do high pressure, long duration hydrodistensions. Those are much too traumatic to the bladder. The American Neurology Association recommends low pressure, short duration to reduce trauma. I had one 3 years ago. It was not a problem. But in the old days, the theory was the more you stretch the bladder, the better. Now we know that's not true. The more you stretch the bladder, the more you can potentially injure the bladder. So now the American Neurology Association is saying we want to use just a small amount of pressure, a small amount of fluid to take a quick look at the bladder, pull it out, and you're done. But the other conversation you need to have with them is what is their plan if they find Hunner's lesions? If they find Hunner's ulcers, Hunner's lesions, because normally they are treated at that time. It would be a great tragedy for you to have a hydrodistension. They diagnose you with Hunner's lesions and they don't do anything about them. Hunner's lesions are normally injected with a steroid, triamcinolone, or they are cauterized. And if they don't do it then, you're going to have another procedure shortly thereafter to treat them correctly. And so make sure they have a plan to treat anything they find. Have that discussion. What do you intend to do if you find a lesion? If they say nothing, you're going to say, why? Why would you do nothing? Because I will tell you, as a support group leader, the number one cause of long-term chronic, and not even just chronic, intense acute pain in the IC patient population is untreated Hunner's lesions. When you treat a lesion, the pain improves dramatically, like 85% or better. And so it's very important that you have Hunner's lesions treated at that time. Sarah says she has news. All right, Sarah, give me the news, girl. I want to hear it. Oh, you met with Dr. Alice Abraham, who started a clinical trial with steroids in bladder installations. Fascinating. What was it? I mean, we've always used steroids in bladder installations. I mean, they've always used triamcinolone or something like that, or Solu-Cortef. So I'm very curious. Send me info. Guys, if you ever need to get a hold of me, my email, ICNetwork, and then I love Macintosh computers. So ICNetwork@mac.com. If you ever need to get a hold of me, ICNetwork@mac.com. I will tell you, I get a couple hundred emails today. I try to go through them all. I did have a lady, after I sent my last newsletter out, she sent me a very hot email saying, I'm not impressed with you. You didn't answer my email, my first email. And I emailed her back and went, honey, I don't have an email from you. I mean, I went through all of my email. It's like, I've never received an email from you. She was flaming mad, but you know what? It is what it is. I do my best. And of course, if you don't hear from me by email, you're always welcome to give us a phone call on our website, on our Facebook page. Just go to icnetwork.org, our Facebook page. Our 800 number is available. You're welcome to call and leave a message. The best way to get a hold of us, especially if it's urgent, is by phone. Your emails are going to get buried. I'm just telling you right now. But again, I do my best. Hello, Billy. Sarah says, anyone in the Eastern United States near Kentucky needs to meet Alice Abraham. So Sarah, we need to make sure she's on our doctor list. Please send me her contact information, icnetwork@mac.com, so I can make that happen. Marisol says, what do you recommend for painful bladder spasms? What we recommend is going to be a smooth muscle relaxant. And that's going to be oxybutynin, also known as Ditropan, and then the other medication is Detrol. And I don't remember the generic name for Detrol, but Ditropan or Detrol, or Mirbitric might help calm some bladder spasms too, but the one that I personally used when I had very bad bladder spasms due to an infection was Ditropan, and it turned off the spasms within about 20 minutes. It's quite miraculous, I thought, at the time. The challenge is sometimes they want you to use they say take an antispasmodic every day. That's not in the AUA guidelines for IC, just so you know. But there are some doctors who might say, hey, you can take this every day. The problem with taking an a bladder antispasmodic every day, is that it slowly deadens your ability to go to the bathroom. And so I think the longest I did it was like 9 weeks. And by the 9th week, I was really having trouble peeing because those muscles had been so massively relaxed by the antispasmodic. So antispasmodics are generally not meant for long-term use. They're meant to be used when you're having spasms. Laura says, how can you tell if you have a bladder infection or if it's just a flare? Well, number one, bladder infections are really known for causing a lot of your hot urethral burning, especially when you're peeing. Bladder infections can cause blood in your urine, visible blood in your urine. Bladder infections, you would have chills, fever, things like that. But the best way to do it is with a urine test strip. And so let me grab one. Where is it? Here it is. And if you're hearing that's rumbling, that's somebody moving something in the next building. All right. So for these moments when you're just not sure, and guys, I mean, like, seriously, my first 2 years with IC, I probably had a urine test every month, because you're just thinking it's infection, it's infection. You don't necessarily understand and know that the only language that the bladder can give and tell you there's a problem with is with frequency, urgency, pressure, pain. So you could have a bullet wound or a stab wound and it would feel exactly like infection. And remember too that sometimes the bladder is a secondary victim to another issue like tight muscles. If you've got tight levator ani muscles, guess what? You're going to have frequency, urgency. You're going to have urethral pain, right? So for these moments when you're not sure if you have infection, one of the things you can do, it's not perfect, but you can get an azo test strip kit, or go to Walgreens and get their own urine test kit, their own generic test kit. Seriously, what are you moving? That's hysterical. Okay. Well, anyway, that's a neighbor. Okay. So on your test strip, you're going to have, I want you to see this right here. So this is what the test strip looks. You basically just pee on it, and it's going to have 2 white tabs on it to start, right? So the top tab, the top test tab is for leukocytes, white blood cells. The bottom tab is for nitrites. Nitrites are only produced by bacteria. And so you pee on it, and if you get a double positive, so if the bottom pad turns bright pink and the top pad turns purple, then slam dunk, you probably have an infection. You call your doctor, you take a picture of it. You can just take a picture of it with your cell phone, email it to your doctor. Hey doc, guess what? I thought it was a flare. I think it's infection. I did a test strip. I'm positive nitrites. Can you please order a urine test so that you can go leave a urine sample so that they can identify the bacteria and give you the correct antibiotic for that, right? But if this is negative, let's just say, here, it's so hard to do this. Okay, let's just say the nitrite tab is purple, but the bottom tab, the leukocyte tab is purple, but the nitrite is. What that means then is you've got white cells in your urine, which basically is what we see in flares. That your bladder has at some point in time been irritated, maybe by drinking coffee or some sort of chemical exposure. And because your bladder wall is a bit more vulnerable, your body is sending white blood cells to the area to protect you. But it's more of an injury rather than an infection. Where is my, hold on. So if we look at this picture here, let's look at this picture for a moment. So this is a 3-dimensional picture of bladder tissue, right? Of quote unquote a mucous membrane. So what we've got is a layer of mucus over the top. Of course, it's not really blue. It's actually clear, but this is for educational purposes. And then you got this nice, thick, robust mucus layer that acts to protect your skin from whatever's in your urine. Then you've got urothelial cells, which is the actual skin, the urothelium. And then underneath that, you've got blood vessels and nerves. See, so there's some blood vessels and there's some nerves. But what happens if you lose some of your coating? Let's just say you did ketamine, which would have basically eaten off or caustically removed some of this coating. Or let's say that you're menopausal. And unfortunately, this nice thick coating is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of coating and lots of protection. When you're older, you have much less estrogen, therefore much less coating. So what happens then is whatever's in your urine can now reach here. It reaches this area. Now, what's amazing is that these, you would think that these would be like passive cells, right? You would just think that they would just be protective, but they communicate to the body. And what they do, there's this whole communication pathway here that they're just really trying to understand and research. But these cells signal the rest of your body that there's a foreign invader and it needs help. And what happens then is your immune system will then send white blood cells to the area. So the white blood cells come up and they swarm through the blood vessels, right? So they swarm up here and they're prepared to kill, because they basically were really thinking, again, 10 million years ago, 5 million years ago, whatever, that it would have been some sort of bacteria that the white blood cell, your army, needed to kill. But there's no infection here for some people. It's just superficial irritation because they don't have mucus. So your body's sending all these white blood cells up here, and that's why you end up with white blood cells in your urine. But so that doesn't necessarily mean. I hope that wasn't too geeky. Might have been a little bit geeky. I apologize for that if it was. There's more. I try not to dive into the science. Let me check YouTube here. Gosh, hello, YouTube guys. It's nice to see you guys. When I'm looking down, I'm tending to look at YouTube. Donna says she can't wait to try Allopath. Barbara says, I want to try it so bad. Holly says, why does the pudendal nerve entrapment produce food sensitivities? Now, isn't that a great question? Oh, do we have to get, okay, so I got to get my geek on here. So irritated nerves release something called substance P. Substance P is damaging. So think about, now I'm not going to say this is 100% correct, but when you get shingles, if you've ever been around anybody who's ever had shingles, shingles is a virus that lives on a nerve. The virus gets active and you break out in a rash, right? And it's a painful, agonizing rash. Some of the redness in that is because the nerves are releasing substance P. Substance P is damaging to tissue. And so if the nerves in your bladder wall are super, super irritated, they are releasing a caustic substance, substance P. Now, and so again, if we go here, so let's look at this. So here we've got these nerve endings, right? And they're releasing this irritating substance that is now turning everything red. The one thing you can't see in this picture is you also have mast cells in here. So when you get a mosquito bite, what happens? The mosquito injects venom, and then the mast cells release histamine, which causes itching and burning. Substance P does the same thing. It causes the mast cells to release histamine. The more histamine you release, the more irritated the nerves get, the more substance P happens. So you get stuck in this vicious cycle of nerve irritation, triggering mast cells or mast cell activation. So to make this is only kind of the end point of your question here. How does pudendal neuralgia cause diet sensitivity and a breakdown of the bladder wall? It's because the nerves have become super, super irritated. And the nerves are very close together. The pelvis is a very small, confined place. We know that nerves talk to each other through something called neurocrosstalk. We know that the nerves all merge at the spinal cord in the same location. And as a consequence, if a nerve in one part of the pelvis is irritated and damaged, it's going to start involving other nerves that also become irritated and damaged. And so that is why you're going to have some diet sensitivity, even if your fundamental problem is primarily a muscle nerve issue. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved. They are both involved. If your bladder is screaming because you have an infection, your pelvic floor muscles will get tight. You cannot stop that. That is called the guarding reflex or a viscerosomatic reflex, right? And so there you go. There you go. Kathy says, I'm very excited about trying Allopath. I've been on Desert Harvest Aloe for a year now, but it is very expensive. Can't wait to try this. I'm also on the Bladder Builder and had no symptoms for 2 months. Yeah, baby, that's what I like to hear. But you weren't able to afford the Bladder Builder and the aloe vera both last month. You're in a flare again. You know what, guys? I'm going to tell you a secret. Just between you and me. Nobody else can hear this, right? I mean, this is a secret. That if you call me and you talk to me and you tell me that you have, that especially now with COVID, that if money is really, really tight, call me and we will give you a discount, like as big of a discount as we can give you, you know, like 20%, something like that, 25%, something like that. So word to the wise, don't talk to my staff. They can't do it. You talk to me. And if you just let me know that things are tight right now, and things are tight for everybody right now, I totally get it. We've already reduced prices. Allopath, Peora is $24 right now, $24.99. That was me going to the manufacturer saying, hey man, things are tight. People can't afford stuff. At least let's give them the pure pain fighting formula at a super, super low cost. And so anyway, call me and let's talk. I'd be happy to try to help if I can. Carol, does IC make your bladder feel very heavy as if you're carrying a child in your bladder? Pelvic congestion syndrome does. If you're walking around and throughout the day, you get more and more and more and more heaviness where you feel like you're carrying a bowling ball around in your pelvis. Generally, what we see with that is either pelvic congestion syndrome, basically the equivalent of varicose veins in your pelvis, or really, really, really tight pelvic floor muscles, where you feel like sometimes when your pelvic floor muscles get super tight, it feels like there's a foreign object stuck in your pelvis. For me, it's like there's a fist up my vagina grabbing onto my tissue and trying to pull it out of my body. That's what a pelvic floor spasm feels like to me. So on the lead story in our magazine, where is it? What did I do with it? There we go. Okay, our spring magazine, working on the summer one right now. One of the lead stories was on pelvic congestion syndrome. And the cool thing, so it gives you all the symptoms of what pelvic congestion syndrome is, and it's remarkably easy to treat. And so there you go. The challenge is in men, the varicose veins are called varicocele, and because you can see them on the scrotum and in the testicles, you can easily see it in guys. It's much more recognized. But in women, the veins are inside your body. You can't see them easily. And that's why they don't get as much attention. Diana says they are out. The astronauts are out. Yes. Carol says, should I try Allopath even though I've never tried aloe for my IC because I have IBS and I'm gluten and lactose free? I'm pretty sure it's gluten free and hold on. And naturally formulated without milk, gluten, wheat, egg, shark, sugar, soy, shellfish, sugar, tree nuts. For individuals with a sensitive stomach, start with 1 capsule once a daily and gradually increase. You know, and again, kind of for those of you who know me, you know I absolutely come from a less is more perspective anyway. I don't believe in taking a lot of everything, especially when you're first trying something. Hello, redhead, super sensitive. And so while a recommended dose may be 6 or 4, depending upon the supplement you're taking, you might be fine with 1. And so that's why you start with 1, wait 24 hours, see how you feel. You can do 1 a day for a week, see how you feel, and gradually work up. But ultimately, in the end, it's about finding what feels good to you. And I know for me, I never take a full dose of anything. I am way too sensitive. So when I take supplements, I take 1. And they work for me. I mean, they do. I haven't taken Allopath yet because, like, literally, this is the first time I've held this in my hand was last night and this morning. But again, what I find for me is that low doses work fine. And if you're financially limited, then that's ideal, right? Oh, Sarah, I'm glad she's on our list. April says, if we suspect subtype 3, should we consider a nerve block? Well, subtype 3 is pelvic floor dysfunction. Subtype 4 is pudendal neuralgia. And so pudendal neuralgia basically means that a nerve in your pelvis is being compromised, usually by a muscle that's tight. So you would have very clear positional symptoms. You would be fine when you stand, but you would have pain when you sit down, or you might have shooting pain down your leg, or you might have a fasciculation or a fluttering. Mine is just starting because I have a partial pudendal nerve entrapment in my left butt cheek from piriformis syndrome. So I talk about this every meeting. Usually within an hour, I start feeling this twitching right there, which I'm feeling right now. It doesn't hurt. It's just a twitching. It's telling me to be attentive to that. Positional pain, you're fine when you stand, but when you squat over, it hurts. Or if it's shooting down your leg, sciatica-like symptoms, that really suggests that we've got a compromised nerve at play. And that's when they would be considering nerve blocks. And God, where was that? Might have been a research paper in the last 2 weeks that went over all the different types of nerve blocks that they can use. I will try to find that. I will try to find that. Oh, Sarah says Kenalog is the steroid. Yeah. Diana says the other astronaut is out as of 20 minutes ago. Yeah, baby. Baclofen is a skeletal muscle relaxant. You've got 2 different types of muscles. You've got smooth muscle of your bladder, striated or skeletal muscle of your pelvic floor. They require different muscle relaxants, totally different muscle relaxants. So for bladder spasms, you're going to use diterpen, Detrol, something like that. For your skeletal muscle, you're going to do either Valium or Baclofen. Baclofen that's B as in boy, ACLOFEN. Baclofen is recommended because it is non-sedating. You can take it during the day. You can normally drive with it. Of course, everybody's different. You got to try it and see how you feel. But it's not like Valium or Flexeril that can be a little bit more sedating. So Baclofen is preferred for people who've got to get out and work and do whatever they need to do. Carol says, what do bladder spasms feel like? Is that when all of a sudden the need to urinate comes on urgency and you can barely make it to the bathroom? No, that would be, you've got 2 functional nerve groups in your bladder. You've got alpha afferent nerves, which control frequency, urgency. And then you've got C fiber nerves, which control pain. So the alpha afferent nerves are nerves that are very easy to turn on because they're the nerves that tell you when you need to pee. They're the nerves that give you that sense that I better find a bathroom. And so that urgency, that sudden need to urinate is probably an irritation of the alpha afferent nerve. For me, the one time I had really, really, really bad bladder spasms, it was with a bladder infection that we thought was a flare for a couple of months, and I thought it was a flare, and I didn't go. I mean, listen, I've only had 2 bladder infections in the last almost 30 years. And I've had IC for 27 years, right? And so I thought it was infection, blew it off, didn't really do anything about it. It's like, all right, it's a flare, no biggie. What I didn't know is that it was just getting worse and worse and worse. And then all of a sudden, what was happening is when I was peeing, as the last couple of drops were coming out of my urethra, I would get this violent pain shooting up my spine and down my legs. And so, like, literally you're on the toilet, right, peeing, and then all of a sudden you're like, oh my God, right? And you're laying that like that for like 5 minutes to wait for that bladder to release, right? For that muscle to calm down. It's kind of like, if you've ever had the runs, food poisoning, something like that, where you're just in that agonizing cramping stage as the that is coming out of you, you don't move. Like you're literally sitting on the toilet just going, oh God, right? And then eventually everything releases. And so that's the way I experienced bladder spasms when I had them. It's just as the last couple of drops were coming out, I would get this violent sensation literally up my spine and down my legs. It was agony. Hello, Natalie. Natalie says, am I familiar with ureaplasma? Yes, I am familiar with ureaplasma. What's your question? Her question is, I was just told that moxifloxacin, I don't understand how it could help since there is. Natalie, I don't understand. You were just told about moxifloxacin. I don't understand how it could help since there is no bacteria. Hold on. You had a hydrodistension. You were told only 40% of your bladder functions. Somehow after 5 years, I was able to train my bladder. However, the pain is unbearable. Could that be IC, no bacteria? So again, you are truly an anatomical mystery to be solved. There's absolutely no doubt about that. And so the question is, so your bladder, you have the hydrodistension, you're told that 40% of your bladder functions. Okay, so they must have done another test to show that. After 5 years, you were able to train your bladder. However, the pain is unbearable. Natalie, can you tell us about the pain? So Natalie is over on YouTube because, guys, we're simulcasting on Facebook and YouTube. So Natalie, describe the pain for me. Where is the pain located? And guys, this is really important. You have to be able to describe this clearly for your doctors when you get your second opinions. So Natalie, where is your pain located? Is it in the center? Is it to the, okay. So Natalie says lower abdomen. Okay, I need you to be more specific. Where in the lower abdomen? Is it, okay, in the center? Do you have, is your pain internal or external? Do you have any external pain at all, or is it all inside of your body? Center, deep. Do you have vaginal pain also? Are you having any vaginal symptoms at all? All internal. Okay, I got that. But now let's see if we can differentiate a little bit more here about where your pain is located. So Natalie says, that her pain is centered in her lower belly, that she had a hydrodistension, 40% of her bladder functions, that you've been able to train your bladder, but the pain is unbearable. So you're having spasms. So Natalie, when they looked inside your bladder, what did they see? What did they see? Did they give you pictures of what they found in your bladder? Did you have Hunner's lesions? Did you have petechial hemorrhaging? Anything? Okay. So I was going to say this is good, but it's never good. But okay, so you had Hunner's lesions. What did they do about the Hunner's lesions? That was in 2011. All right, what did they do about your Hunner's lesions at the time? Now, y'all remember, what did I say? What did I just say 20 minutes ago? In the patients that we work with who have had long-term pain, the number one thing we see is untreated Hunner's lesions. Natalie, I am so pissed off for you. Those lesions needed to be treated. Bladder installations do nothing for lesions. I mean, they might temporarily numb it, but a lesion, let me show you a picture, hun. This is why, guys, this is why we say before you have a hydrodistension, you got to have a discussion with your doctor about what the hell are they going to do if they find a lesion, right? So I want you guys, now, whoops, hold on. So let's look at a picture here. Of course, so Natalie says nothing has helped and it's gotten progressively worse. Natalie, that's why your lesions haven't been treated. Lesions respond to lesion-specific therapy. Elmeron, nothing else is going to work. What works is if you inject a steroid into the center of the lesion. So look at this. These are lesions in 16 different patients. This was published in one of the papers. So lesions are known for what we call a stellate appearance. There's a center. Feel like there's a center, there's a center. So you can see the center, right? And then they tend to have arms radiating out of it. Okay, so the question is, and one of the enduring mysteries of IC, although we have good theories, right, is why do lesions develop? Why the hell do lesions develop? Because it was Guy Hunner, the Dr. Guy Hunner in the 1920s, who was the first to describe lesions. He helped invent the cystoscope. He's the one who first saw these, which is why they called Hunner's lesions. So why does a lesion develop? There are two fundamental theories here. Theory number one is that it is a nerve that is massively irritated. And here's what we know. And okay, look at this picture for a moment. This is petechial hemorrhaging, glomerations. This is what we see in patients with IC subtype 2 bladder wall driven, okay? This is what we see in IC subtype 1 Hunner's lesions. Not the same. Not even close to being the same. So theory number one is based upon biopsy results, because when you biopsy the center of this lesion, it's massive inflammation. Man, it is a biological war. Remember, your white blood cells are your warriors. They're the ones that defeat infection for you. And so in this patient, when you biopsy it, massive inflammation. In this patient, when you biopsy it, no inflammation. And so the great majority of patients do not have inflammation. The ones who have the inflammation are the Hunner's lesion patients. So it's a war happening. So concept number one is it is a nerve that is massively inflamed, releasing a ton of substance P, which is causing this tissue damage. Or the Europeans made a pivotal discovery about 5 years ago where they found viral infection. This could also be a virus living on the nerve that is infecting this. And we know this is possible because if you had ever had to have a kidney transplant, you know they would put you on anti-rejection drugs, right? They would suppress your immune system. When you suppress the immune system, a very specific group of viruses that are part of the human body. I'm not talking STI. I'm just talking viruses found in the human body, okay? the polyoma BK virus gets turned on in people who are immune compromised. And it causes bleeding wounds. It is associated with what we call hemorrhagic cystitis. So Natalie says, moxifloxacin, I was told may help because it might be ureaplasma. Well, listen, hon, if you really want to know what the hell could be in there, you would want to instead have a next generation urine test. Go to bladderhealth.org. There are a couple of videos of doctors over there who use this. All the big current research studies related to any sort of infection, bacterial, fungal, viral, they're now using next generation urine tests. No, ureaplasma is not a virus. Ureaplasma and mycoplasma is a distinctly difficult to culture infection that I also think is very small. Nancy says, I started showing IC pain after I had shingles. Could that be related? Yeah, definitely, because it irritates nerves. Definitely. So there's a lot of, I'm trying, you're hearing me hesitate because I'm going through the library in my brain. Hold on a sec. Let me just look at something here real quick. So that's what they do. They use next generation testing, PCR testing, to detect ureaplasma from a urine sample or a vaginal sample. And so that's what you would do, hon, rather than guessing, because you're guessing. Everybody's guessing. And hon, you've been suffering since 2011. It's time to stop guessing. You need facts. And if you want to know 100% sure you have ureaplasma or mycoplasma, this is the test you have. You have a next generation urine test. It's $199. Okay, worth it. Worth it. Because it might not be that. It could just be a nerve that is just massively, massively inflamed, or it could be a viral infection. Now, in Europe, they've now associated a couple of different viruses in the urine of patients with Hunner's lesions that they have not found in the urine of patients without Hunner's lesions, right? And so it's polyoma BK, it is Epstein-Barr, if you've ever had mononucleosis, they have found that. Lyme disease is not viral, but we've even found Lyme disease bacteria in the bladder, right? And so that's one. It's challenging. It's challenging. Okay, so stop guessing. Don't guess. You need facts, and you have to have a test to prove it. And then ultimately, in the end, honestly, I think the reason why, again, we don't know, and you don't know, and they don't know. Have the test. If the test comes back negative, then what you have to do is you got to have the lesions treated correctly. And that means they need to inject it with a steroid. That's what the American Urology Association says. You either inject it with a steroid, triamcinolone, or you cauterize it, or you can do hyperbaric oxygen therapy, or we have the first device in history to heal Hunner's lesions. And unfortunately, it's not available. It's called Lyris. Lyris is a very interesting story because Lyris, it was researchers at MIT years ago, 15 years ago or 12 years ago, whatever. They were trying to find a way to deliver medication to the bladder, because the problem with treating the bladder, if you put medicine in the bladder, you pee it out. So how do you get your medication to stay in the bladder over a long period of time? So they created a medical device. It's like a hollow piece of spaghetti filled with medicine. And what they do is they put it in the bladder where it kind of coils up so it can't come back down. And for a 2-week period, medication is released by this little noodle, for lack of a better term, 24 hours a day in the bladder. And so they created it to help with pain. And the very first thing they did, the first medication they used was lidocaine. And they were stunned that in the very, very first study that was done in Canada with like 12 to 15 patients, half of whom had Hunner's lesions, they did a hydrodistension before and a hydrodistension after. And guess what? The lesions were gone after 2 weeks of a numbing agent. 2 weeks of a numbing agent. And so that points us right back to nerves, right? So if you numb the nerve consistently over time, the nerve calms down, the redness goes away, the lesions heal. The lesions heal. The quote was, because I had a patient in the study call me and say, my lesions are gone. And I'm like, what? How did you do that? And they told me about Lyris. I had to sit on it for a year until they published the study. I was talking with the researchers about it, and the researchers were floored. We have never, ever, ever seen Hunner's lesions disappear and the tissue to be perfectly normal afterwards. 2 weeks. 2 weeks with Lyris therapy, lesions healed. Total and complete resolution of the lesion was the quote in the first research study. Then they did multiple more research studies to again try to establish that. And they had every doctor who was using it in the study found lesions reducing in size, reducing in number, going away. It's L-I-R-I-S, Lyris. Allergan owns it. Yeah, that's right. That's how you spell it, L-I-R-I-S. Allergan owns the device. They bought the device from the other company, and they have shelved it. They shelved it last year, and you can't get it right now. The only treatment in history to heal lesions. And so, Natalie, if I were you, I would just say, hey guys, I've got Hunner's lesions. You've got Lyris. Why can't we do this? Why can't I use this? The quote, I emailed the research coordinator, product manager, whatever. It was what did they call it? It was de-emphasized, something like that, in their product portfolio. And they didn't explain why, but normally that happens because they don't believe that it's going to make them enough money. So they deprioritized it. It's called deprioritized. Well, they didn't have a chance to make money because it was in research studies. They were doing research study after research study after research study to prove it. And again, every year, every urologist in the study found Hunner's lesions improving. But for one reason or another, they deprioritized it, which is a great tragedy, because I've worked with patients who they want it back because their lesions came back and they want it back. So why would lesions come back? And the answer would be that the nerve is continued to be irritated, or perhaps the virus has become active again if it's a viral infection. So Natalie, come on over to our website, icnetwork.org. Please check the section on treatments. Go to the Hunner's lesion area, and you can learn all about that. Now, guys, normally we also do a Zoom meeting, and so let me pick that up so that you can come right into the meeting and ask your questions, so you're not just hearing me, you can hear each other. Hold on a sec. Let me start that. Hold on, my friends. Hold on. Let us see here. All righty. All right, so the Zoom meeting I have just started. Let's see here. All righty. Hold on a sec. All right. So on YouTube and Facebook, I'm going to go ahead and paste the invitation. Oh, wait, hold on a sec. Whoa. Hold on. That's just way, that link was way too long. No. All right, hold on. Ooh, it's hot. I'm getting hot. I always get hot during these meetings. All right, YouTube, you've got your invite. I just put that in there. Facebook. All right, where's my Facebook? There's my Facebook. Marianne says, 2 weeks ago, I found you and I took some advice and bought a Therawand and slowly relaxed my tight pelvic floor muscle. Pain is much reduced. Mary Ann, yes. Good job. Good job. It's weird. All right, so Facebook, I'm going to post your Zoom invite in. And you guys, please know that when I post in, I can't go back and look at a lot of your questions. And so please ask it again. Okay, the Zoom invite is in there, April and Carol. Carol, okay. Carol says, I've taken your advice. I'm getting lidocaine installations twice a week. How long should I do these? And then should I have them done once a month? So the published protocol for rescue installations, according to Dr. Parsons' original research, was you would do 3 a week for the first 2 weeks, and then once a week for a month, and then as needed. Sarah says, here, the reason I asked is that there are a few ladies in my IC support page that only have frequency, urgency, and have a healthy looking bladder. So if you've got a healthy looking bladder, that's good. Then we want to look at structures outside of the bladder, right? Okay. Oh my God, I'm so hot. Okay, guys, tell you what, let's just take a minute break. Go pee, go get your glass of water. I'll be right back. I need to take a break too. Okay? And then we'll start our Zoom meeting. If y'all want to Zoom, if you don't want to Zoom, that's fine. I'm good with it either way. If you come into the Zoom meeting, just know that I do have to manually bring you in. And so, and let me know if you're having problems. Oh, wait, hold on. That's my OBS. That's not what I'm trying to do. Where are you? Okay, there you are. Zoom. No. Wait. No. Wait. Wait, hold on. Now, it showed I started the meeting. It says I'm in the meeting. Switch to portrait view. No. Oh, come on. Technology, right? No, that's not where. Oh my God. Wait. It's being weird. Wait, I have too many windows open. Okay, I gotta find it. Oh, there you are. Oh my God. Okay. Marianne, you're coming in. Natalie, coming in. Lauren, you're coming in. Too many windows open on my computer. All right, guys. 30 seconds. Go do what you need to do. I will be right back. And mute yourself. Go ahead and mute yourself unless you want people to hear. Okay, hold on. I'll be right back. Righty. Okay, Natalie, I just admitted you. So guys, we're going to be having a one of the attorneys involved with the Elmeron lawsuits. We're going to do a special event with them the second week of August. So you can come in and ask questions because that is a big deal right now. Okay, so hold on a second. Let me just get back. Okay, Facebook, I can see you. Woohoo! I'm always worried I'm going to accidentally shut something down. YouTube, I can see you too. Excellent. Tammy Ann says, my doctor wants me to have Botox injections. Has anybody done them before? Botox are step 4 treatment options in the AUA guideline. We have a 6-step protocol for IC. And so normally you start at step 1. You do everything in step 1 before you go to step 2. You do everything in step 2 before you go to step 3, step 4, step 5, step 6. So in step 1, we've got the basic self-help. In step 2, we've got basic therapies. Step 3, we got pelvic floor and lesion treatment. Step 4, we've got neuromodulation and Botox. So what Botox does is Botox will temporarily numb or silence those nerves, the alpha afferent nerves, which are driving the frequency urgency. Botox can be injected in the bladder wall, and Botox can also be injected in very, very, very tight pelvic floor muscles. The challenge with Botox is that, you know, when they, so like, here's your bladder, right? And so they basically, you know, inject it in a lot of different spots. If they accidentally inject it on the nerve that controls your ability to pee, you will not be able to pee on your own for a brief period of time, a week, a couple of weeks, a month, a couple of months. And so you're not supposed to have Botox if you are incapable of self-catheterizing, because that is a specific risk of having Botox therapy. And again, if you go on over to icnetwork.org, you can learn more about that. So again, for anybody new, my name is Jill Osborne. This is a live IC support group meeting. We are talking about bladder pain, pelvic pain, muscle pain, anything that can contribute to that. As much as I would like to keep talking, it's important that you hear each other and you have an opportunity to tell your story. And that is why we start a Zoom meeting. And so for those of you on Facebook and YouTube, I am here, but I'm going to be looking at Zoom and letting people tell their story. And I'm just going to go ahead and paste that link back in. So Facebook, there's the link again. Dawn says, here, hold on. Let's look at Dawn here for a moment. We're here. Newly diagnosed, my issues, frequency, urgency. Do you recommend bladder rest? I take desert harvest aloe and pumpkin seed oil. So, and Shara's saying, did the link work? Okay, I know the link's working because there's 5 people in here. But are all you guys that got in here from YouTube? Okay, try the link again. If the link, let me know if you tried it again. All right, so Dawn.
I'm from YouTube.
Oh, wait. Here we go. Hold on. Okay, you guys, try to mute yourself. Let me finish here for a moment. And then I will bring you on one at a time. So Dawn, it's important that we understand why at this point in time you're struggling with frequency urgency, because it doesn't just mean that it's your bladder wall. It could be your pelvic floor. And so over on our website and on our Facebook page, I have a video called The 5 Subtypes of Ic. It's important that we try to understand what your unique presentation of IC is so that we can talk about the right therapy for you, right? So subtype 1 is Hunter's lesions. Subtype 2 is bladder wall driven. Subtype 3 is pelvic floor driven. Subtype 4 is pudendal neuralgia, that's nerve driven. And subtype 5 is central sensitization. So a bladder coating, an over-the-counter coating, is going to work the best for IC subtype 2 bladder wall driven. And so if your symptoms began after hysterectomy, or if your symptoms began maybe even after starting birth control. We have our first case study that followed an 18-year-old who suddenly developed very severe symptoms, and over a period of a year they tested her for everything, nothing worked. It was her birth control. A year later, she goes off the birth control, her pain goes away. All of her symptoms went away within 2 months. And so in that context, using something that contains chondroitin will have the best result at protecting your bladder wall. And that is from research studies. Research studies have found that chondroitin bladder installations are the most effective at restoring the integrity of the surface of the bladder wall. And in Europe, you can get liquid chondroitin. It's called Uricist. It's available in Canada. It's available in Europe. Or it's Ialuril, which is a combination of chondroitin and sodium hyaluronate. Unfortunately, none of these are available in the United States because they have not gone through FDA approval. Again, this is for IC subtype 2 bladder wall driven, where there's a bladder wall deficiency of some type. And so the next step that we would do is something that the American Urology Association supports, which is the use of over-the-counter supplements. And so based upon the chondroitin research, I personally believe that the most important supplement to try is one that's going to have a true bladder coating effect, and that's going to be a chondroitin-based supplement. And so Bladder Rest is chondroitin. It's a very clean, simple formula, all made in the United States. But it's not the best one. The best one is Bladder Builder, because Bladder Builder has, in addition to the chondroitin and the glucosamine and the quercetin, it's got collagen for the bladder wall, it's got beneficial probiotics, but most importantly, it's got PEA, palmitoethanolamide, which has been proven in research to